Hello, good afternoon, gentlemen. Before we start off, I would request the attendees to come forward, please. The hall is looking very scattered. Thank you. I would request my co-chairperson, Dr. A.K. Gupta, to please come on the side. We would be starting off the foot and ankle symposium session 1, and we have a very good list of luminaries from abroad, from UK. Our first talk is by Dr. Karthik Hariharan. There's a slight change. Dr. Simon is not here. Dr. Karthik would be presenting ankle instability. Dr. Karthik, please.
Thank you, Mr. Chairman, ladies and gentlemen. This is a talk that was prepared last night after a few glasses of wine, so bear with me. I'm going to talk to you very quickly about the anatomy of the ankle, particularly with regard to the lateral anatomy of the ankle, which is where most of the instability is. I'm not going to talk about medial instability, which is a separate lecture. We'll talk a little bit about the pathogenesis and the reasons why people get pain and instability, signs and symptoms, and its management. So if you looked at the ankle ligaments, particularly on the lateral side, they are the weaker of the ligaments. They consist of the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. The talocalcaneal capsule also plays a role in the stability of the ankle, as will become evident later. Isolated medial ligament injuries are quite rare, but they do occur from time to time. If you look at the syndesmotic ligaments, which are a different group of ligaments which bind the tibia to the fibula, you've got the starting from above down, you've got the interosseous membrane, the interosseous ligament, and you also have the anterior inferior and the posterior inferior tibiofibular ligament, which sort of comprises the syndesmotic ligament. These ligaments are extremely strong, as you know, and they bind the two bones at the distal tibiofibular joint very strongly, and they are responsible for the so-called high ankle sprains. If we looked at the stability is afforded primarily by the bony structure, the talus being recessed into a mortise, which is very strong, in addition to the ligaments, but also the stability is influenced by the position of the limb. In the dorsiflex position, the ankle is much more stable because it's in the closed packed position with the maximal width of the talus incorporated into the mortise, and in the loose packed or the unstable position, the ankle is in plant flexion. So how do sprains occur? And the mechanisms have been extensively studied, and they're thought to be, I'm talking about lateral ligament sprains, so they're thought to be as a result of excessive or over-supination of the rear foot, that's the ankle and the subtalar joint, about an externally rotated force. The anterior talofibular ligament is almost always first injured, and then the calcaneofibular ligament, although the calcaneofibular ligament has got a higher load to failure. If you increase plantar flexion, in addition to supinating the limb, that further increases the risk of injury. There are different grades which have been described, which are quite useful in management. If the ligament is just stretched and there is some interstitial damage done to the ligament, then it's a grade 1. If the ATFL is torn and the CFL is intact, it's a grade 2. And if both are torn, it's a grade 3. I would categorize a grade 4 where there is dislocation sometimes without fracture, where there is, in addition, a large anterolateral capsular rent. If you look at the biomechanics, the subtalar joint is a pivotal factor in influencing lateral ligament instability. The ground reaction force acts through an axis which exits the forefoot between the second and the third toes, but in this position the ground reaction force stabilizes the foot, acting as an everter and a dorsiflexor. So in dorsiflexion the ankle is stable, and if you evert it, the lateral ligaments are intact. So if you looked at the force that is required to move that ground reaction force line across, the more lateral it comes, the more dangerous it gets. And also, the more plantar-flexed the foot is, the more dangerous it gets for the lateral ligament complex. What about the effect of shoes? I mean, we've all heard about the high heel footwear, and it becomes pretty evident. If you look through YouTube, there are innumerable numbers of videos which will show interesting model failures, but you also see this severe supination of the foot resulting in the injuries, as I mentioned before. There's been an interesting theory of instability where Trop postulated two kinds of instability. One is mechanical or true instability as a consequence of ligament failure, where he noted that the ankle motion in inversion is beyond the physiologic limit of its range of motion. Functional instability, on the other hand, is a perception of instability, and the patient feels unstable. There's a subjective sensation of ankle instability, and this is thought to be due to a lack of or a defect in proprioceptive function of the ankle and its surrounding neuromuscular units. But usually in clinical practice, this is often a combination where you have mechanical instability, which is painless, and pain only occurs after the inverting event, and functional instability, where pain actually causes the sensation of the ankle giving way. And so you've got a bit of an overlap, because over a period of time, mechanical instability will almost inevitably lead on to functional instability due to loss of proprioception. So there are various causes for it in the anatomy itself. If you had pathologic laxity, the traditional hypermobile syndromes, they are known to be notorious for lateral ligament injuries, although they seem to cope very well with it. If you have a tight tender Achilles, you're putting the ankle into a loose-packed plantar-flex position because you're unable to get the heel to the floor. Similarly, with cavus, where the hindfoot is in varus, you cause a supinatory force, the ground reaction force is lateralized. There are other intra-articular lesions which can cause features of instability, but not true mechanical instability. Clinically, you localize the area of tenderness, and it's often very well circumscribed, particularly with anterior talofibular ligament injuries. You've got a variety of tests, including your anterior draw and impingement tests, and also inversion stress testing. You can test for the syndesmosis by doing a squeeze test where applying compression between the tibia and the fibula causes distal pain. To test anterior subluxation, you use two methods, whichever is convenient for you. You either stabilize the foot on the couch in the supine position and move the tibia to see if it can move, or you can put the leg over the couch and try and pull the talus forward. Either way, you'd find that a greater than 5 millimeter translation anteriorly of the talus relative to the tibia is pathologic. Sometimes you can see the sulcus sign, where you can actually see the capsule being sucked in as the fibula moves backwards. This is a sign of significant instability. You can also do a talar tilt test by either using x-rays, where you put the patient prone, where you can assess the hindfoot position and compare the sides. The squeeze test is where you exert proximal pressure and elicit distal pain. So, if you looked at it in practice, ankle stability is actually controlled by the subtalar joint. So the integrity of the subtalar joint is pivotal for the ankle to be stable, because when you strike your heel to the floor, there is a torsional or a torque force that's initiated at the subtalar joint axis. So any abnormality in the orientation of the subtalar joint, or if there is equinus, or if there are structural or architectural situations where you've got an inverting force, increases the risk of injury to the lateral ligament complex. So investigations, you can use plain X-rays, which may not give you much information, but stress X-rays certainly will. This is a test of true mechanical instability in order for the ankle to be able to sublux, except in very rare conditions, particularly with hypermobility. Ultrasound has been proven to be a very useful technique because it can be done real time. It can be done whilst stressing the ankle, and a lot of us have tended to use this as our primary method of assessing instability, particularly in the anteroposterior axis, because it really measures less than 2 millimeters of shift anteriorly. You can use local anesthetic injection if it's an acute injury. MRI scan is largely to pick up other issues, particularly with intra-articular lesions such as loose bodies or osteochondral fractures. These various forms of pathology really form the bulk of the functional instability group of patients. Conservative management is the norm for most strains of grade 1 and grade 2. 3 to 6 months of physiotherapy often improves proprioceptive function and thereby improves the functional instability component. So as a rule, if the ankle is painful and then the patient complains of instability, you tend to do an MRI scan. If it is unstable, then you tend to do a screening. If there is pain and the patient is complaining of functional instability, various studies have indicated that just merely debriding anterolaterally will probably resolve the problem. And there was a presentation by Patrick Lang in 2004 at the British Orthopaedic Foot and Ankle Society, which confirmed that. If all of this fails and after 6 months following arthroscopy there's still significant instability, then one may consider surgical reconstruction. There are two kinds that you can attempt. One is to attempt to restrict movement in the subtalar axis, and these are the non-anatomic repairs, which is the Evans and the Watson-Jones. But the standard fare for most foot and ankle surgeons and sports surgeons indeed would be the Brostrom-Gould procedure. The non-anatomic really is reserved for revision surgery. So this is the modified Brostrom, where there is a direct isolation of the anterior talofibular and calcaneofibular ligaments, which are reefed after being shortened and connected to the fibula. And then there is an augmentation of the repair by using the inferior extensor retinaculum. Most patients with instability have functional instability, and very few of them will have true mechanical instability. If it is painful, then you must treat the pain first. Screening will identify mechanical or true instability for you. If there is pain, do an MRI scan. Arthroscopy will cure 75% of these patients. If needed, proceed with reconstruction. Thank you very much.
Would you take the questions right now or
Yeah.
after the second talk?
Yeah, we can take it after the second talk, sir. That'll be
I
fine.
think that would be better.
Okay.
We'll continue with the Dr. Karthik will continue with his talk on ankle impingement syndrome.
We're continuing on a similar theme. Ankle impingement syndrome is in fact one cause of functional instability, and so it dovetails quite nicely with my previous talk. It is a syndrome, so it's a collection of symptoms largely involving soft tissue, although there can be some bony involvement. Usually involves some crushing between bones in and around the ankle. It's often a young patient who complains of impingement type symptoms. There's often an index injury. If you ask the patient, he'll be able to give you an episode where he said he had a particular injury and this is when it all kicked off. Occasionally there can be non-traumatic causes, particularly with inflammatory conditions such as rheumatoid arthritis or tumour, where particularly with pigmented villonodular synovitis may occasionally cause impingement, although it's rare. You can broadly classify ankle impingement syndromes into anterior ones, the posterior ones, and some rare ones which not strictly ankle impingement but around the ankle, such as subfibular impingement and severe valgus of the hindfoot. If we looked at anterior ankle impingement, if you looked at a normal ankle, there was a study done by Nick Van Dyke who showed that in the normal ankle there is an anterior space which is usually filled with fat and synovium. And if you arthroscope the ankle, you can usually find this. If you dorsiflex the ankle to about 15 degrees, you find that there's a significant decrease in this space. And this causes a squeeze of these tissues, which can be picked up on an MR scan. And it is probably this area where you get the propensity for anterior impingement, particularly if there is significant hypertrophy of the synovial structures in front of the ankle. There are several causes for anterior or anterolateral impingement. A common cause is where you have an avulsion or a tear of the inferior leaf of the anterior inferior tibiofibular ligament, which is the anterior syndesmotic ligament. This can sometimes cause a meniscoid type lesion where it incorporates the anterior synovium of the ankle and acts like a meniscus and catches between the anterolateral borders of the tibia and the fibula. It's seen in 70% of patients who complain of anterolateral impingement, and an MRI scan is highly specific to pick up this condition. So this is what it looks like. There's a hypertrophied appearance of the anterior inferior distal tibiofibular ligament, and an arthroscopy, you can actually debride it very nicely. This is an excellent operation if the diagnosis is confirmed. On the other hand, you can get bony pathology, where you get bony spurs that arise from the anterior rim of the tibial plafond, as also the tibia. It was initially thought that these were traction osteophytes, but now we know, again, study from Toll in Holland, that these are not true osteophytes. They're traction osteophytes because they lie deep to the capsular insertion on the tibia. On the tibia, you'll usually find that these are lateral to the midline, and on the talus, they're medial to the midline, and they seem to lie within the capsule. Sometimes you can get capsular calcification, which can also cause the problem. I don't think it's a direct crushing between the two bones, but it is the crushing of the soft tissues to the anterior space that usually causes the problem. There is actually a classification of the grade of spur, although it's difficult to work out what it actually is useful for. If you looked at the clinical signs and symptoms of anterior ankle impingement, it's classically anterolateral pain, and it's very specifically located by the patient. The patient can also give a history of locking or catching, and they describe classic features of functional instability, where they get a sharp pain and they feel that their ankle buckles under them, quite the opposite of mechanical instability, where you buckle over and then the ankle starts to hurt. You can get an effusion or synovitis on occasion. The Molloy-Bendel test is probably the best test you can use, and it's a validated test. And Steve Bendel, the current president of the British Orthopaedic Foot and Ankle Society, wrote this paper with his fellow. It is 95% specific, and it largely consists of applying a force with your thumb over the area of tenderness in the anterolateral gutter region, and then to dorsiflex the ankle. It is 88% specific and has been correlated with MRI scans in subsequent studies. So physiotherapy, lots of stretching is often utilized initially. You can use an injection into the anterolateral gutter, which can sometimes be quite therapeutic, although largely it is useful to allow the patients to undertake their stretching exercises. Arthroscopy is a very useful technique if after a few months of physiotherapy you get no relief. A spur can be excised very nicely by using the arthroscopic technique, as well as large areas of hypertrophied synovium. What about posterior impingement? It's less common in the general population. It's probably much more common in jumping sports like basketball, and in dancers. It's particularly known to occur quite frequently in classical ballet dancers. I'm not sure as to whether it affects dancers in the Asian subcontinent. What are the causes for it? The fundamental basis behind how this occurs is when there is trauma in equinus, which is why it occurs in patients like ballet dancers and basketball players. It's often a force that's posteriorly directed as the ankle is plantar flexed when the patient lands, and basically what happens is the structures behind the talus get nutcrackered or crushed between the tibia and the calcaneus. It's often associated with injuries to the posterior tibiofibular ligament, posterior talofibular ligament, the posterior inferior tibiofibular ligament, which is the syndesmotic ligament, and it can also affect the deep tibiotalar component of the medial deltoid complex. It's often referred to as the posteromedial impingement syndrome, which is there. So you can have a variety of causes depending on what structures are involved at the back of the ankle. You can get a flexor hallucis longus tear or synovitis, which can cause hypertrophy behind the ankle as the FHL traverses almost in the midline. You can get a posterior talar process fracture, which is less common, but it has been known to occur, causing again impingement and pain. Or you could get the os trigonum syndrome, where there is the accessory ossicle of the posterior process, which may or may not be attached to the talus itself, which is crushed in the process. So the classic symptoms are pain on loading of the ankle, particularly in equinus. You can get pain which is tracking along the flexor hallucis longus tendon, and you can get symptoms of catching and giving way of the ankle with locking, particularly if there is significant synovitis to the FHL tendon. And the trick is to palpate the joint line posteriorly. It's often easy to sort of try and press too close to the Achilles tendon, and you might mix up a diagnosis of Achilles tendinopathy with it. So you'll have to be deep to the tender Achilles, and often test it in maximal plantar flexion. Sort of jerking movements of the ankle in maximal plantar flexion will elicit painful symptoms. You can also do resisted FHL tests to see if that will elicit pain in the flexor hallucis longus. There is a posterior Malloy Bendel test, but this is not a validated test. Now, I haven't seen any papers that have validated this particular test, but it seems logical that you could perform this. Investigations, this is largely a clinical diagnosis, and it's actually quite easy to pick this up if you knew the examination. You can have radiographs and flexion which will pick up alteration in the position of the os trigonum or a fractured posterior talar process. An ultrasound is again very useful because you can do that with the patient standing up on tiptoes, and you can pick up pathology. MRI is probably ideal when there is difficulty still in picking up the diagnosis. You find the source of pain, assess the posterior joint, and it's highly sensitive and specific for pathology. It's an example here where there is arthritic change between the os trigonum and the posterior border of the talus. The treatment is stretching, lots and lots of stretching with the physiotherapist in dorsiflexion. You can inject it under ultrasound guidance. Arthroscopy is very useful. You've just noted that you can see the flexor hallucis tendon that you can release through posterior arthroscopy, and this is an os trigonum that's being ground away by the arthroscopic burr. It is extremely important that you have an extended period of physiotherapy after this procedure, because many of them will stiffen up very quickly because they are reluctant to pull their ankle up, and if you get a lot of posterior capsular scarring, you can certainly have considerable difficulty in rehabilitating this patient. So posterior scarring is bad, particularly in an athlete. Thank you very much.
Thank you, Dr. Karthik. Any questions to Dr. Karthik's talks?
Sir, how would you define an ideal footwear that can prevent such ankle injuries? Any definition till now? Any recommendation?
This is a big industry in sports medicine where there are several methods of preventive interventions. This is largely the domain of the physiotherapists who look after, for example, professional football teams. There are a lot of strapping techniques that are undertaken, but I think nothing equates to appropriate strengthening and training. Proprioceptive training is probably the best preventative method. There's been a lot of money invested in footwear, and there's a lot of orthotic adjustment of the foot, particularly in a cavus foot, where you might want to try and, in a 4-foot driven cavus foot, where you can reposition the heel in an appropriate position. But I think the mainstay would be strengthening exercises to try and get your everters nicely strengthened up. And that,
what about the prevention aspect?
Probably what Karthik means to ask is about the general public, not about the
about the general public. Oh, right, okay.
Yeah.
Well, in the general public, I mean, ankle instability is either due to an injury, they stepped on a curb and they twisted over. Oh, I don't know how you can prevent that. We'll have
High
to.
heels, of course, we can prevent.
Of course.
Fashion heels, we can prevent.
Yes, I mean, are you going to prevent?
Fashion coming up.
Let's say you've got a 20-year-old daughter. Are you going to stop her wearing high heels?
We can
I don't think
prevent a
so.
catwalk also.
My daughter, I couldn't prevent her from wearing high heels. But, I agree with you. I think if there are obvious factors in it, it's certainly worthwhile trying to prevent that. I mean, there are new high heel fashions that have come up where they're more platforms rather than stilettos like the models wear, which I thought to be a bit more stable.
Thank you.
Milind?
Question for you. I don't know if it's relevant.
It's always relevant coming from you, Milind.
I've treated a lot of equinus deformities through the years, and I find that a lot of equinus deformities, when they're corrected,
They become lax.
tough ones, with distraction. Later on, I've found many of them to develop an anterior osteophyte in the talus, like your footballers.
Okay.
It's almost as though, perhaps if we do it wrong and if we don't distract the joint enough, it's almost as though the cartilage is heaped up.
Yes.
I see it early when you're doing it wrong, and I see it late even if you've done it right. And can you shed some light?
This is on the talus, is that right?
It's on the
Yeah,
talus.
I think in the talus, capsular calcification is not unknown. I've seen that in a couple of my patients, where I've used distraction techniques, where I think it's capsular distraction. It's interesting you say that when you've done them early, because even when you correct equinus early, you'll still have to distract. You don't allow them to hinge. I mean, you overcorrect, is that right? And I wonder whether overcorrection might be causing some chondral damage to the front, because one of the theories as to why these osteophytes develop is thought to be because the articular cartilage, both on the tibia and on the talus, seem to extend past where normal articulation takes place, and it is thought that these are I keep calling them osteophytes, they're bony spurs, really. And one of the theories, I can't remember the name of the chap who wrote the paper, it says it's possible that it's chondral injury that's actually causing it, even though it doesn't form part of the main articulation. Clearly, if you've corrected your equinus and your dorsiflexion is way past physiological dorsiflexion, then there will be direct impingement.
That would be easy to understand.
Yeah, that's right. So it could well be.
In absence of such excessive dorsiflexion,
Yeah,
I've seen
yeah.
it. And the other thing I was wondering was, have you seen a talar structure like a femoroacetabular impingement? You have many equinus when they present late to us in their 20s, 30s, 40s,
Yes.
etc. They have there's
They've got
loss of the offset of the.
That's correct, yes. I mean, again, I suspect that that's a developmental thing. Where there's been long-standing equinus, I suspect it's developmental molding of, just past the articular surface is what you're saying, isn't it? Yeah, no, I'm convinced that that's the developmental thing related to the abnormal anteriorly directed stress on the talus.
Correct.
I mean, I can't prove it to you, clearly.
Yeah, and you would take it off along with your soft tissue release.
Yeah, I have struggled with that because you never know how much you have to take off.
Correct.
That's always been the problem. You never know. Is that if you take a little off and you X-ray it, you think, gosh, I haven't taken enough off. And when you actually in the operating theatre, you're using your chisel, you think, my goodness, I can't take such a big chunk off. So it's a difficult call, but I think it comes with. I mean, I'm sure you've done several thousand more than I have, but I'm sure it comes with experience. Yes.
Thank you.
Karthik, one question I have regarding the bony spur that you talked about anterolaterally. What size would you neglect? What size would you excise?
I don't go by the size. So I know size is
By the
important,
complaints?
but I don't go by size. I go by the symptomatology. And if the patient complains, there can be very small lateral osteophytes which can cause significant symptoms. And there are other very large osteophytes which are particularly in footballers. I mean, every footballer will have one of these. Not all of them cause symptoms. So I don't think size really would be the issue for me. I would probably go by the level of symptoms. Thank you very much.
One
Sorry,
question.
sorry, sir.
There is any radiological correlation with the symptoms of the stroke?
I think impingement is largely a clinical diagnosis. I think you can almost pick up virtually every impingement patient clinically, and I think your radiology is really an adjunct to make sure that you haven't got anything hidden behind it. I think that's. I'm sure the other faculty would agree on that. I mean, it's largely a clinical diagnosis that you pick up, and you do an MRI scan simply to say, okay, this is what is, particularly in posterior impingement. If there are several structures there that could cause this impingement, and you use the MRI to pick out the potential culprits that are causing the symptom.
Thank you.
Okay, thank you very much.
The next talk is by Mark Davies. Ankle osteochondral lesions.
Mr. Chairman, ladies and gentlemen, I'd like to thank you all very much for attending the session and for the invitation to speak here. I'm Mark Davison from Sheffield in the chilly north of England. I'm going to talk to you today about osteochondral lesions of the talus, and it ties in an awful lot with what my friend and colleague Mr. Harry Haran has just talked to you about. A few facts and figures. We're dealing with a pathology which by and large we see in the younger age group, and that's certainly a relative youth compared to the ageing population in the UK. It's about 3 times more common in males compared to females, and it represents about less than 0.1% of all fractures and about 0.1% of all talar fractures. Certainly seems to be related to the supination external rotation pattern of ankle fractures, and I'm sure if we were to perform arthroscopy on these patients after fixing these fractures we would find this more common, and is probably associated with 6.5% of all ankle sprains. And given that ankle sprain is the most common presentation to any accident in emergency department around the world, there is some significance in this subject. And certainly as an incidental finding, or perhaps as a part incidental finding, it can be in up to a quarter of the patients undergoing ankle reconstructive surgery. So in acute trauma, as I said, it's a small percentage of talus fractures, but this inverted lesion that you can see here on the plain film, where it's inverted through 180 degrees, and then better imaged here on the CT scan, shows an acute osteochondral fracture. And in my practice, and certainly the literature, seems to support that fixing this through a small arthrotomy is a successful procedure, and here just using an absorbable implant to peg it back into place is a good result at 6 months. And I'm sure is the right thing to do rather than excision, although excision may be necessary in a comminuted fragment. The history of osteochondral description, it's been described following the presentation of a loose body in 1922, and then what I regard as the seminal paper in 1952 about astragalus fractures by Coulthard is also described there. And then in 1953, Roden described quite an extensive series of patients with this pathology, which subsequently led to the Burnton-Harty classification, which you're all very familiar with. So, coming back to the basics and the patient history, has there been a history of trauma? And that's a very key point, because clearly it is related to trauma, but it may be that that isn't the case. Some lesions may be associated with non-traumatic origin. It may be possible for us to localise the pain, so to ask the patient to point where the pain is, but we have a paper in press, or in process of being in press, from Sheffield, which actually shows that patients are not able to locate with their finger the exact size of the pathology in terms of the symptoms. There may be swelling, there may be instability, and this is where it ties in with the previous talk, is that this can be a presentation of the patient saying their ankle is unstable. And of course if there's a loose fragment in the joint, then it goes without saying locking may be a presenting complaint. Just one thing I'd like to remember to tell you is that sometimes the pain can be worse nocturnally, so after a day of rest it can be a pain that is associated with being in bed at night. On examination it's important to look for hindfoot alignment, because as we've heard earlier, the varus valgus alignment of the hindfoot is crucial. Swelling may very well be a finding that you find particularly in the acute setting, but it may be a transient thing that comes and goes. And that may be a true effusion, or it may actually represent a synovitis, a reactive synovitis. As I said, the tenderness may be localisable, but it isn't necessarily so. There may even be an altered range of motion and a draw sign, because it may be associated with instability. Plain radiographs I think are helpful, because as you can see here, and I hope you can see it, is that lesion there is clearly visible, and certainly we're used to making that the mainstay of our initial investigation. CT and MR. Now, I think it's very much up to each individual as to what they find useful. Some proponents of CT, such as Van Dyke, and there are some proponents of MR, and some people, like myself, will use a combination of the two, depending on what we're trying to look for. But it's certainly very useful in terms of trying to size the lesion, and that certainly gives you an idea therefore about offering a patient a prognosis. As you can see here, the MR clearly shows that the lesion is there, but there is an awful lot of reactive edema below the lesion, and that's a telling change that you can see on MR and no other investigation. Here you can see again the MR clearly shows a lesion. So taking you through the Burnton-Harty classification, which I mentioned earlier, they described 43% of lateral lesions, mainly in the middle third, and they felt that these were associated with a history of an inversion and dorsiflexion injury. 57% of them were medial lesions, and they often occurred in the posteromedial aspect. And when they took a history, they felt that there was a large relationship between inversion and plantar flexion. That doesn't quite fit with what we've heard today. And then subsequently developed this classification, which you can see here. Luma then also added to this classification in terms of using CT scans to look for radiolucent lesions on a plain film. There have been other classifications, including arthroscopic and also CT and MRI, and one from Bristol here I think is quite useful, particularly in detecting deep cystic changes, which I think have a negative correlation with outcome. But there isn't one easy way of using these classifications as a tool in terms of research and transfer of information. So again, we'll just talk about these posteromedial. In my opinion, a lot of them are atraumatic. They're not always symptomatic, and often they've probably been present for years before they're finally uncovered by your investigations. And they're often deeper and more cup-shaped, and I feel they have a much poorer response to treatment. Anterolateral ones, I think there is a history of trauma. They're shallower, and I certainly feel that they're receptive to treatment. Indications for surgery will be failed physiotherapy, persistent symptoms. Obviously, a large intra-articular detached body shouldn't be left alone. Acute trauma we've talked about. And then it's just a question of making your choice as to what to do, because there is a whole menu of options that you have available here. Excising the fragment, doing a chondroplasty, open reduction internal fixation, obviously in the acute setting, microfracture and drilling, osteochondral grafting, mosaic plasty, autologous chondrocyte implantation, and bulk allografting have also been written up, as well as there are some prostheses on the market. Now, I think most of us would try and do something simple, which has got a little bit of basis in the literature, and these guys, particularly this gentleman, has written an awful lot about it. Just simply arthroscopic debridement and drilling is a very good option. It's a one-step procedure, and often return to profession sports in about 4 months with good results in over 70%, and I think that would probably mirror most people's practices, particularly with the anterolateral lesions, as I mentioned. A paper from Australia showed that you can do this procedure again. So in other words, if you're presented with a patient that's had the procedure before, there is some merit in repeating it, because even though it's a small series, this was a series of over 1,000 arthroscopies that were performed by the lead author, and we still found that it was important to do this procedure because a significant number of them even made a recovery to return to professional sport. ACI, this is taking sample cells, culturing them and reimplantation. That apparently means that you can do it on an unlimited area, but the trouble is there's often underlying bony loss, and I think that's difficult to manage. It was designed and is thought to therefore mean there's less donor site morbidity than a mosaic plasty, which we'll talk about very briefly. And there's this perception that it will give you hyaline cartilage, and I'm not entirely certain that we can say that in security. But there are papers that show that there are results of 90% in a lot of cases, but it's 2 operations, it's quite costly, and it is technically very difficult. And these are 2 papers, particularly this latter one here, again, has come from one of our British colleagues in Oswestry, and it showed good results in inverted commas in a small group. Mosaic plast, you can see here taking, this was popularised by Haggerty, and this is taking plugs of measured bone from the lateral aspect of the knee and implanting into the talar deficit. And again, this has been associated with some decent results. The trouble is with it is donor site pathology. It's quite difficult to match up the pathology. There's interposed fibrous tissue. There's a risk of fracturing both at the donor site and at the talus as well. And it only has a limited amount of space that you can use to do this technique, and often use it.
Any role of nuclear scan before localizing signs have appeared?
I think that certainly in the UK, the availability of nuclear medical scanning is diminishing. We're finding it difficult to get the isotopes, and we're finding that MR is offering more sensitivity and better at localization than a hotspot on a bone scan. So we're doing less and less of that. You can combine it with CT as a SPECT measure, but that's not widely available in the UK.
Any other question?
What usually is the time gap between the symptoms being persistent there and you get to confirm in CT or MRI? What is the time gap?
I think it depends on whether it's an acute injury, which is obviously diagnosed very acutely. But a lot of these patients are referred in with chronic instability and lateral ankle pain, and will have had failed non-operative measures, so that can be 6 to 12 months after their index injury. In those that are post-remedial, then that's not necessarily quantifiable, because I think they are a different beast and they certainly behave differently in terms of their treatment.
Now, almost all the cases you are doing with arthroscopy.
Yes, absolutely. Apart from the obvious open procedures where a malleolar osteotomy may be required, but yes, arthroscopically, I think has been my practice. Has been the workhorse of my practice. Ravi.
What's your preferred procedure?
I prefer, as I was saying, I prefer an index arthroscopy. I find that very helpful, and I seem to get a reasonable result in a large proportion of patients. And in some patients, I'm quite prepared to do the second arthroscopy after a period of time with physiotherapy and unresolved symptoms, because I do have the confidence from that paper I mentioned to you that actually there's a high chance that they will make a good response to that. After that, I think a third time you won't be lucky, and you may have to change your strategy. And I have to say my tendency would be more towards a mosaicoplasty.
First time you do microfracture?
Yes, that's right.
In case you have to approach a post-remedial lesion.
Yes.
So what approach do you take to reach that lesion?
Well, I think so long as you know where you are relative to the FHL tendon, you could try that arthroscopically, and certainly arthroscopic manipulation from the posterior side, particularly posteromedially, has been written up by the Bristol group, but that obviously makes it more difficult. But I think that a transmalleolar drilling has been advocated as well, and I think if you're skilled with that, then that's a possibility.
In case you have to do an open procedure for a lesion which is a drop of tails, you can't see by arthroscopy. So what approach do you take?
Right, so you're talking about a very central lesion and very far back. Well then, I think you'd have imaged that preoperatively, and I think that'd be a very reasonable thing to then turn the patient prone and do a prone arthroscopy, or even a patient in the lateral position to give you a good posterolateral access and anterolateral access.
And you have decided for mosaicoplasty?
Mosaicoplasty would be a supine and an osteotomy.
Well, in a lighter vein, sir, what's the best and the worst movement of the table?
Sorry,
Your best movement and the worst movement of the table during arthroscopy.
the best moment is when I
You
think.
jumped with joy.
Right. Yeah. I'm not sure how to answer that one, but no, I don't know what to say to that one. I'm sorry.
Worst one, any worst moments also?
Worst moments is actually it was never on the table. It's always going to be with the results of your surgery many months down the line. But I in terms of intraoperatively, I wouldn't like to say. Thank you.
Well, thank you, Mark. The next talk is by Dr. J. Mangwani on acute tendo-Achilles rupture. It's a debate, and Dr. Mangwani would be speaking for the non-operative methods.
Good afternoon, everyone. Thank you, Mr. Chairman. Before we load the talk, whilst it's happening, I'm sure all of you have treated a tender Achilles rupture at some point. Can I have a show of hands how many people have treated an acute tender Achilles rupture at some point in their career? Pretty much all of us, yeah? So if we were to treat a 35-year-old chap who's a weekend warrior, what would your preferred method be? surgical or non-surgical. We're not going into details of which surgery or what, or non-operative treatment. We just want to see how many people consider surgery as their preferred method of. So, yeah. What about non-operative? So more in favor of surgery. Chris, I have a tough job to do.
Yep.
Right. Let's see if we can change the opinion. Okay. Let's go. Righty ho. So we're going to be debating, and essentially we're looking at a bit of evidence, a bit of our own practices, because we're two centres in the UK practicing different sort of preferred method. We'll give you some of our results and let you choose what you want to do, and we'll have about 2 or 3 cases scenario at the end, and we'll quite like you to get involved and tell us what you would do in those scenarios, so that we can have a bit of a debate. And that's the whole point of doing this session. So, as we've outlined, that's me. Bit of the anatomical bits that we need to know about tender Achilles. As it comes down in last sort of 6 centimeters, it twists through 90 degrees. And there is a zone of relative avascularity about 4 to 6 centimeters from the insertion. Biomechanical considerations is strongest tendon in the body, and as you are running, you're putting about 10 times your body weight through it. So it is a lot of weight and forces going through the tendon. And it is a complex, the whole complex spans 3 joints. As you grow older, as I am now, athletes have higher injury susceptibility, and you recognize that picture. So about 18 per 100,000, and the incidence is increasing. And there are 2 peaks, 30 to 50, and then you've got your more sedentary patients afterwards. The etiology is multifactorial. There is an element of degenerative changes which can be responsible. Certainly drugs, steroids and fluoroquinolones, your ciprofloxacin, one of the culprits there. Hypothermia is one of the theories, and mechanical factors. Imaging, it depends. It's essentially a clinical diagnosis, and a lot of people will argue, and I would argue, that acute tender Achilles rupture, you really don't need any further imaging. If it's a complete rupture, you should be able to diagnose it through clinical examination. But if you were to use it, you're looking at ultrasound as one of the dynamic ways to confirm, and also confirm the gap. Imaging continued, you're looking at MRI as one of the other options. It's a static image that you're going to get. It is good when you're not sure whether the tendon is completely ruptured, or you want to find out more about degenerative changes, which we'll learn in tendinopathy section. So we're going to come to the crux of the matter. We want to know how to fix it, how to deal with it. So non-surgical, we'll look at the evidence for cast immobilization, functional bracing, and also surgical. Do you open your tender Achilles for surgery like a traditional open approach, or do you do it through a minimally open or a percutaneous? And Chris will be covering the surgical aspect of it. Okay, so lots of queries there, and let's see if we can answer some of it. So what are we debating about? I just want to make sure that we all understand this. We're all sort of singing from the same hymn sheet. It is an acute rupture which is loosely sort of put into first 7 days or 10 days. You're not looking at 3 months down the line rupture to be treated. The debate is not about that. We're not debating about the myotendinous ones, because there is good evidence out there that they can be treated non-operatively, and neither are we debating about open ones, because I think, if you treat an open Achilles rupture, you are getting something fundamentally wrong. It has to be debrided and surgically repaired. So, and if you then divide into non-operative and operative treatments, they're not as simple as one non-operative versus one operative treatment. So whatever you do, look at the literature, you won't be comparing apples for apples all the time. And what constitutes non-operative treatment? So we all have, certainly when I was as a postgraduate here in early days in the UK, cast was the main form of non-operative treatment. You put people in cast, equinus cast, and then you gradually got them out of the equinus cast. In the last few years, certainly there's been more emphasis on the functional bracing or accelerated kind of non-operative management. And there is no consensus as such, if you look at the literature, to see which one is better. And why are we debating? The reason we're debating is in 2004, through that Cochrane review, we learned that the re-rupture rate with the non-operative arm was almost 4 times as high, and as you can see in those figures. But there is emerging evidence that in last few years, the non-operative treatment has the same outcome and re-rupture rates. So that's why we're debating. This is our Leicester, where I work, protocol. All of our patients, by default, if they're diagnosed with an acute tender Achilles rupture, will go into one of these fancy boots. It's manufactured by IOACON. Essentially, what I want to bring your attention to, it's got a rocker bottom sole there, and also there is a locking screw at the back there. So your initial, when you're diagnosed with an acute rupture, you're going to go into a 30 degrees of equinus, which that bolt will lock it for you. And then we'll look at rest of how it progresses from the rest of the protocol. So at 2 weeks, they come for a change of liner, which is the liner underneath the boot, an assessment by a surgeon. At 4 weeks, there will be another change of liner and dynamization of the IOACON pad through the screw that I showed you. So you lower it down so that you can move the ankle between 30 and 15, right? So it won't allow you to go any further up from 15. At 6 weeks, you will mobilize it further to 30 to naught, so you're neutral but no dorsiflexion. And at 8 weeks, you'll be assessed by the physio and the doctor again, and you'll be started on a tender Achilles rehab program. At 12 weeks, most of our patients are discharged to physio. This is 118 patients that have been recruited in a prospective data. A colleague of mine is collecting these. And again, we're talking about within 7 days. We've got about a year's follow-up, not 2 years yet. And their mean acute tender Achilles rupture scores are 75. We've had 2 re-ruptures. One was somebody who took the boot off at 4 week stage. And also we have 3 VTEs, a DVT and a PE. So what does the current literature say? Why are we having this debate? Why not just, if you do surgery, you're fine. If I do non-operative, that's fine. Why are we having this debate? The debate is about these papers in last few years. And as you can see, in 2010, this paper came out saying the surgical and with accelerated rehab and non-surgical with accelerated rehab is exactly the same. So you're doing surgery for no reason. And there's no difference in outcome, including their re-rupture rates. This then went on to, there was another paper the following year, and a couple more that I've not sort of, for the in sake of keeping to time, haven't mentioned. But again, same theme here. At 1 year endpoint, their outcomes are exactly the same. This time they put surgery in a plastic, with surgery in a plastic cast, and non-surgical patients in a plastic cast as well. And this is the meta-analysis. So if you meta-analyze data from all the studies, and this is published in the American Journal, as you can see, they recognize that the re-rupture rates are similar. The conservative treatment centers, if they're using functional rehab, i.e. what I showed you previously, should consider non-operative treatment. And non-operative treatment certainly has less complication rates, and we'll come to that debate once Chris has done his talk. And if you look at the last line, they've suggested that you should consider surgical repair if you are thinking of not going through the accelerated rehab. So here's a question. I play badminton and tennis, and every time I go on the court, I think maybe it's going to be one of those days today where I'll have to limp out of the court. So what would I have? Anybody's guess? No, definitely not. Anybody wants to guess? I'll have one of these. It's a no-brainer. Thank you. I'll hand over to Chris, and we will take questions after the cases that Chris is going to run through. Thanks, Chris.
So it's interesting that JIT Centre, my centre, are about, how far apart are we? About 40 miles, straight down a motorway. Take you about, probably about 45 minutes to drive from JIT Centre to my centre, and we do it completely differently. It's this Achilles debate here.
So Chris would be taking on Mangwani for the operative.
I am. Thank you. So I'm Chris Blundell from Sheffield. I work in the same centre as Mark, who was talking about osteochondral lesions, and we both treat our Achilles tendon ruptures in the same way. So we can agree, Jit and myself, that we're not going to operate on myotendinous ruptures, and there is lots of literature to suggest that these patients do very well with non-operative management. And I don't think we need a lot of debate about patients who are non-compliant, people with peripheral vascular disease, and diabetics. Studies suggest that tendon apposition clinically on ultrasound and treatment in a boot with early weight bearing do have a good outcome and do have a re-rupture rate, however, of 7%. It was interesting that Jit said, well, we don't need to debate about open injuries because clearly we're going to fix them. I'm not sure I can see the logic there, really. You've got an open injury, you're clearly going to take them to theatre because you need to debride them. But if you debride them and the Achilles tendon is sitting there looking at you, but it's clean, and the edges can be opposed, why not just stitch your skin and treat them in a plaster, Jit? Why not do that? Because your tendon ends are opposed. So you change your tack for an open injury. I'm not sure I quite understand that. Clearly, we would fix them. What about the operative techniques? Well, Kessler sutures and Krakow sutures and Brunel have all been described in Achilles tendon repairs. The problem is when you do that very often you end up with the foot in quite a strongly equinus position. And quite often it's difficult to then repair the paratenon afterwards because you end up with a bunched up and humped up Achilles tendon through a long approach. And this is partly why the operative techniques for Achilles tendon repair have become questioned in recent times because of wound healing problems. But I think some of that debate about old-fashioned techniques in Achilles repair are not appropriate, and the risks that Jit like to talk about for operative repair may not be represented in current and modern practice. Percutaneous repairs, of which there are many, but Marr and Griffith are probably the most famous, with a series of sutures passed through the Achilles tendon and out as a weave, again have moved on to more modern techniques like this, which is a jig which has some holes across it, and that jig gets passed through a very small transverse incision up either side of the Achilles, and the sutures are passed through the jig on the proximal end and on the distal end through a 3 centimetre transverse incision, which we think has a lower risk of having wound problems. So it's an incision that big at that site, and the tendon ends are sutured together with a positive squeeze test at the end and a very small, very low morbidity wound. There are no morbidity wounds, of course, so I'm prepared to accept that if you don't create a wound at all, you're not going to have wound healing problems. So why do we operate on them? Well, fundamentally, the literature does suggest that a conservative Achilles tendon treatment group has a higher re-rupture rate, and those meta-analyses that Jit referred to, with the exception of the most recent American study, which may not actually represent a UK practice, suggest that the re-rupture rate is higher in non-operatively managed cases. Surgical treatment has got a higher complication rate other than re-rupture, and that's really fairly obvious, I think. So the two more established, perhaps, meta-analyses that have been published over the last 8 years have both suggested that there is a significantly lower risk of re-rupture with surgery. On the first occasion, that was a 4 times reduction risk of re-rupture with surgery, and the second time it was a 50% reduction in re-rupture rate with surgery. Well, so what? Surely, all these risks that we've got of surgery must outweigh the benefits of a non-operative management. Well, I think re-rupture is a really big deal. if patients do re-rupture, it's often missed because re-ruptured Achilles tendon is not always a painful condition. The patients who re-rupture sometimes present just with poor progression, that they're not doing well, and they come back at 3 or 4 months, sometimes from the physiotherapy department, with this patient's failing to progress because it's a gradual tearing apart of a tendon that probably never healed in the first place. And it's more difficult to reconstruct a tendon that has re-ruptured with turn-downs and grafts than it is to repair them in the acute setting. And we know that the repairs that are done in late re-ruptures do less well in the long term than those that have had a non-re-ruptured tendon, whether that's because they've been managed non-operatively or operatively. And I think there are further risks if you're re-operating on people or operating on people for a second period, because that's a more prolonged period of immobilisation. We know that patients with Achilles tendon ruptures pose a high risk of venous thromboembolism, and to put them through that twice is a significant risk to their well-being. In Sheffield, we've got a 3-year retrospective group of patients. These patients looked at over a slightly longer group longer period than the Leicester group, but I think that's probably not relevant because the patients that re-rupture will re-rupture inside 1 year, by and large. We've got a slightly larger number, but not significantly so. But we've reviewed more than half of these patients. Our mean age is 43, with a mean follow-up of 2 years. Our Achilles tendon rupture score is marginally better, but probably not significantly so, than JIT's group. We do treat them all post-operatively in the same way as we treat them non-operatively. So if we do have a patient who doesn't require surgery, our rehabilitation from that patient who's being treated conservatively is identical to the treatment that we would give a patient who has had surgery. And the reason for that is that we believe that repairing the Achilles tendon only brings the Achilles tendon ends together. It doesn't afford power to the Achilles tendon, it just makes sure that the ends are together so that if and when they heal, and hopefully they will heal, the Achilles tendon is the right length, and by bringing 2 ends together they will heal. If the ends aren't together, they won't, and that's the same of a bone or skin or anything. So we put them in an air cast boot after a gravity Aquinas cast for 2 weeks. We let them weight bear throughout. At 4 weeks we start taking the wedges out from underneath, so that at 6 weeks they're neutral to the ground, and they get rid of the walking boot then and are just got going at 6 weeks. We discharge our patients from our clinic at 12 weeks. What are our results? Well, we've got a 6% surgical complication rate. That's because we've got 7 infections, of which 3 were deep, all of which resolved by removing the suture material. That's a 5% wound problem. We've got a 1% sural nerve problem, and we've got marginally less DVTs and PEs than the Leicester group, but without a doubt not significantly so, and those DVTs and PEs are probably not related to the surgical management, and of our 140 plus patients we've not had a single re-rupture. So we've got a surgical complication rate of 6% and a re-rupture rate of 0%, whilst we know from the meta-analyses that a non-operative risk of re-rupture is 9 to 12%, and that re-rupture is a very bad event. And for that reason I believe that operative management is better than non-operative management. We adopt in Sheffield a pretty pragmatic approach. So what we actually do is, if the tendon ends can be brought together and demonstrated that they can be brought together on an ultrasound scan, then we put the patient in a 20-degree cast and we treat them non-operatively. But if there's a gap in those tendon ends, or those tendon ends are coming apart, then we operate